Welcome back to the deep dive. Our mission today is really laser focused. We're decoding the mechanics of safe and effective communication. Specifically, we're talking about those high stakes moments, clinical handover. And this isn't just about, sharing a bit of information. It's about flawlessly transferring accountability. So let's just jump straight in with the scenario, one that, well, we all know keeps clinicians up at night. Picture this. It's 5:30, the end of your shift, and you've got three critical things that all need your attention. First, a patient with chest pain, some dynamic ECG changes, and you're still waiting for that crucial troponin result to come back. Second, an urgent CT report lands in the notes. It explicitly says urgent surgical review advised. And then third, you've got routine TTOs for a stable patient who's otherwise ready to go home. The clock is ticking. You need to leave. How do you actually guarantee safety here? How do you prioritize? And how do you transfer that accountability correctly?
That is the perfect storm scenario, isn't it?
Yeah.
And it shows exactly why safe handover is what we call a must-know topic.
Right.
It's not just some optional structure. It's an absolute prerequisite for patient safety. Our sources, which draw really heavily from GMC guidance, NHS protocols, and even the WHO, all confirm that the goal is to move way beyond just giving an update. You have to transfer the clinical information and the accountability flawlessly.
Okay, so let's unpack that. We're really synthesizing core professional duties here. You've got the GMC, the General Medical Council, which sets that high ethical and professional bar for continuity of care. And then the NHS, the WHO, and ICs, they're providing the tools, the sort of structured methods to actually meet that bar.
Exactly. And here's the central exam truth that should guide every action you take in these situations. Safe handover requires you to transfer accountability with SBAR, a named donor who actively accepts that responsibility, explicit timeframes, and a clear written record. If any single piece of that chain is missing, you still own the problem.
Okay, so that structure, it really matters. It's there to reduce the cognitive load and, I guess, protect against human error. And when we look at how these things are scored in high-space assessments, it always comes down to specific auditable actions. The guidance seems to point to three main pillars for scoring.
Precisely. Pillar number one is clear structure. You have to use SBR situation, background, assessment, recommendation. But it's the R, the recommendation, that does all the heavy lifting in a handover.
That's the point that I think gets missed a lot. We all learn the acronym SBAR, but what is the real function of that final letter, the R, when you're actually trying to transfer ownership?
The recommendation is your concrete ask. It's the moment you transfer the burden of action. You're not just saying, oh, the patient's new WS score is 8. You're explicitly recommending, please review this patient within 15 minutes and prescribe broad-spectrum antibiotics.
Right.
Without that specific ask, you're leaving the other person to try and prioritize your patient against 10 others, and that's where delays happen.
So the second pillar follows on from that. It's accountability and time. This is where you need that named person to accept responsibility, and there has to be a stated deadline, right? You can't just hand over a job to be done, sometime tonight.
Right. And the third pillar, which I know can feel like a time sink on a busy shift, is written continuity. You need concise documentation. What was handed over? What are the specific actions, the timings? And just as important, what are the escalation triggers? It can't just exist in someone's memory.
But let me push back on that for a second. Practically, if I'm running late, the patient's stable isn't a quick verbal SBA enough. As long as the person I'm handing over to is competent, have I not met my GMC duties?
That's a really common question, but the GMC is explicit. You have to ensure a safe transfer of care, and critically, you have to keep clear, accurate, and contemporaneous records.
Contemporaneous. So at the time...
At the time, not hours later. Responsibility only truly transfers when two things happen. A competent receiver accepts it, and the plan is documented. If you skip that documentation, the safety net is gone. And legally, professionally, that responsibility is still with you.
Okay, so let's give everyone listening that practical framework, the one that embodies all three pillars. Our sources lay out a really clear, high-yield structure, the 5-step drill for any handover scenario. Step 1, prepare the essentials. So you're reviewing everything, diagnoses, OBS, risks, and importantly, things like DNA CPR status, the ceilings of care. Step 2 is to structure by SBR. That's for clarity and for prioritization. Step 3, confirm acceptance to a named owner. Get their name, get them to acknowledge it.
Okay.
And then step 4, record with actions and deadlines. This is your primary defense. It protects you and the patient from harm caused by delay. And step 5, which is so often neglected, is paramount. Re-escalate unmet actions on time.
Your job doesn't end when your shift does. You need a plan. for what happens if that result comes back critical 30 minutes later and the person you hand it over to hasn't responded. And to tie all of that together, there's a perfect memory aid straight from the notes. ONIT. It's the blueprint for a safe handover and a high-scoring one.
Okay, let's break down ONIT. What does it actually mean for someone on the ward?
So O is for outline, which is your full, structured SBR. W is for who owns it, a named person or a named team who explicitly accepted the task. N is for notes written. It has to be in the patient record detailing the conversation in the agreement.
Okay.
It's for intervals timeframes, concrete deadlines like review by 01.000. And T is for trigger to escalate. What specific thing, like a new WS of 7 or a missed deadline, prompts the next action? If your handover ticks all 5 of those boxes, you've fully transferred accountability.
O&I is really clear, but I think vagueness is where that accountability changes snaps. We need to be clear about the model language. What does a good handover actually sound like?
It's all about using language that removes any ambiguity. Look at the model phrases. For example, an SBAR with clear timeframes. You move beyond just being general. SBR. Mr. Ali, Ward 7 new WS8 with lactate 3.9. Please review within 15 minutes and confirm antibiotics and repeat lactate by 02.00.
So specific.
You've got the patient, the critical data, the concrete ask, and a time-bound deadline.
And that leads you right into closing that accountability loop.
Exactly. The second example, closing the loop, requires you to get that explicit confirmation. Can you confirm you're taking responsibility for the CT urgent surgical review, and we'll see the patient within 30 minutes? You're forcing the named owner to acknowledge the task and the timeline.
And that is such a big shift from just saying, I told them about it. This is, they confirm they own it.
Yes. And the third example tackles that documentation piece head on. I'm documenting actions, owners, and deadlines now. I'll re-escalate if the review hasn't happened by the agreed time.
You are building the audit trail right there, and you're documenting your own follow-up plan. That's hitting the third pillar of written continuity. Let's go back to our opening scenario then and talk about prioritization, because time-critical situations demand an immediate, really specific handover. What are the universal red flags that should always jump to the top of any handover list?
The guidance is clear on 4 non-negotiable red flags. First, time-critical results that don't have a named owner. So that's your critical troponin or pending bloods for a patient who is crashing. Second, any patient with a high NEWS score or who is clearly on an unstable trajectory but doesn't have a detailed review plan.
Okay.
And third, pending urgent imaging reports where radiology has advised an urgent review, but no clinical action has actually been planned or documented.
And the fourth one, that deals with the really crucial ethical and legal side of things, right? The patient's wishes.
That's right. Sealings of care so, DNA CPR, or other specific escalation decisions that are unclear, missing, or haven't been communicated. This has to be explicit in every handover, especially for high-risk patients.
So if we use those rules to solve our initial dilemma, the chest pain patient, the urgent CT, and the TTOs, how does the prioritization work? They both seem pretty urgent.
They do, but the critical difference here is imminent reversible risk. The chest pain patient with dynamic ECGs and a pending troponin, that represents an acute, immediately life-threatening, and potentially reversible medical emergency. Managing that risk with full accountability is always priority 1.
So the best action SBA, the medical registrar immediately, confirm they own it and ask for a 15-minute review. That always beats, say, calling surgery about the CT.
It does. The CT needs a review, absolutely. But the unstable cardiac patient needs stabilization, diagnostics, maybe even an immediate intervention. You have to secure the patient who is crashing right now first. Calling surgery is critical, but it's secondary to the unstable medical patient.
And doing routine paperwork like TTOs before dealing with 2 unstable situations is just...
It's a dangerous failure to prioritize. It scores critically poorly.
Okay, now for my favorite bit. The classic mistakes. The decoy detectors. These are the low-scoring options that feel really efficient in the moment, but they completely fail the test of accountability. Why do these quick fixes fall apart?
Because they lack that formal structure we've been talking about. Take the first strap answer. Pop it in the group chat.
But hold on, if I use the group chat, everyone on the team can see the message. Doesn't that sort of spread the accountability load and make it safer?
That's the common assumption, and it's completely wrong. The problem is, it's informal, is not linked to the patient's official clinical record, and most importantly, it lacks a confirmed owner. You have no idea who read it, who accepted it, or who is tracking that deadline. It just becomes an everyone's problem, therefore no one's problem situation.
Okay, next trap. Writing really vague instructions, like just putting "for review" in the patient notes.
That's a fundamental breach of continuity. It's completely ownerless. No one has accepted the task. There's no time frame. There's no documented transfer of responsibility. It's just far too vague, and it leads to misdiagnoses.
What about that really common phrase, "tell the ward to keep an eye on the patient"?
This is a classic shift of responsibility, but without any accompanying plan.
Mm.
It's vague. What are they keeping an eye out for? It sets no specific actions, no measurable criteria for what deterioration looks like, and no clear escalation triggers for the nursing staff.
So you're basically just delegating supervision without any plan.
Exactly, without providing senior cover or a definitive plan of action.
And the biggest error of all, leave early, they'll see it later.
This is just a failure of your professional duty. It fundamentally breaks continuity and risks an unsafe delay. You're required to confirm that a named clinician has explicitly accepted responsibility for that patient's care before you leave, assuming a transfer is the ultimate pitfall.
So the golden rule just keeps coming back. Structured SBR plus a named owner, a time frame, and a written record. It defeats all of these traps because it forces clarity and confirms ownership.
Right, let's quickly run through some of the practical questions that come up when you try to apply ONI in the real world. These are pulled from the FAQ section of the source material.
Okay, so we talked about SBR. It's widely endorsed, but is it legally mandatory in the UK?
No, it's not written into law that you have to use SBR. But it is the methodology that's endorsed by the NHS, the WHO, and nice because its reliability has been shown to reduce error. So in any high-stakes situation, using it just aligns you with the highest safety standards.
And what about verbal handover? Is that ever enough, especially if it's a team that knows the patient really well?
Absolutely not. The verbal communication, it starts the transfer, but it is incomplete without a contemporaneous written record. That written record has to detail the actions, the owner, the deadlines, and the escalation triggers. Only that documentation actually secures the transfer of responsibility.
Okay, here's the highest stakes practical question. You SBR the issue, but the person you're handing over to refuses to accept the task, or they challenge the priority you've given it. What do you do?
Your duty is always to the patient, so you must immediately escalate up the chain of command. You go from the registrar to the consultant or the site team, and crucially, you have to record every attempt, the times you escalated, and the names of the people you spoke with.
And in the meantime,
While you're escalating, you have to ensure the patient remains safely monitored. You never, ever leave a known risk unmanaged.
and finally, just circling back to those red flags, how specific do we need to be about ceilings of care?
Extremely specific. DNA CPR status, escalation status, any specific limits on intervention. This is all safety-critical information. It has to be explicit and clearly handed over to maintain care that actually respects the patient's wishes and prevents inappropriate interventions.
This deep dive has really clarified it for me. Safe handover isn't just a chore at the end of a shift. It's a fundamental professional act. It's the transfer of responsibility. And we've really established that critical difference between just firing off an informal update and properly achieving an accountable transfer of care.
And to really solidify that, here are the 3 essential summary points to take with you into your next shift. 1. SBR plus a concrete ask and a deadline is completely non-negotiable. 2. A named accountable owner must explicitly accept responsibility. And 3, always create a written contemporaneous plan that details all the actions and the escalation triggers.
So what does this all really mean? Safe handover, when it's built on that structure of ONIT, it isn't just about avoiding patient harm in the moment. It's about protecting yourself and your team by getting rid of any gray area of ownership.
And the principles we've discussed, the structure, the named owners, the documented plans, they link directly to other critical GMC domains like delegation and supervision and escalating clinical concerns. When you apply these principles rigorously, you create a really robust safety net. You make sure no crucial action can fall into that gap between shifts, no matter how busy things get.
Continuity ensures care never stops, even when your shift does. That's all for this deep dive. We'll catch you next time.